Early Healthcare Data, How to Boil the Ocean by Eran Bellin, Professor of Clinical Epidemiology and Population Health and Medicine, the Albert Einstein College of Medicine, Bronx, New York, VP of Clinical IT Research and Development, Montefiore Information Technology. Boiling the Data Ocean, How to Address Infinite Information Request Demand. What is your greatest existential problem? You are asked to generate reports from your data systems. Your institution's leadership, frustrated by its inability to answer questions, hires more administrative types to ask more questions. You block them with priority queues and data request forms. When those administrators do not get the answers, they hire research analysts for each administrator to fill out your forms and demand in more precise language data pulls from your systems. Your information architecture is a chaotic mess, with separate pots of data in individual systems, each with its own reporting machinery and no way to create information dependent upon cross-system data. You have no credible plan to get out of the spiral of doom. Pretty frightening when you look at it. It's even more frightening now. How do you get out of this mess? What strategy and tools are necessary? This is the subject of my talk, To Boil the Ocean. By the end of it, you'll have a clear option to solve this problem. A solution, not a band-aid. Creating actionable information is a partnership between those who collect data as part of operational activity. For example, your doctors, your nurses, who enter clinical information at the point of care, your lab, pharmacies, radiology department that flow data into your EMR, and administrators filling out forms. So those are the people who collect the data. You have those who create information for consumption. These are your research analysts who've identified important, reusable questions. And you have those who disseminate the information, builders of dashboards. You have a critical role supporting all these activities. How is data consumed? Sometimes as raw display of primary data. An EMR, for example, has lab test results on each patient. An EMR can have chest x-ray text on each patient. There are people who consume data as preformed reports, such as actionable lists. Here's a list of patients who are eligible for mammography. Here's a list of patients who are eligible for colonoscopy. And you have data consumed in the form of preformed aggregation reports, either in paper, or PDF, or dashboard. For example, the percentage of eligible patients who receive timely colonoscopies by year in clinic. What do these three have in common? The raw display of primary data, the preformed action list report, the preformed aggregation report. What do they have in common? You know in advance the exact question you need to answer. You sometimes forget this assumption. For example, when you use Excel or some other slicing and dicing business intelligence tool, where you filter by clinic or pivot by gender, you feel like you're creating new knowledge with all the plasticity you need. You have an illusion of flexibility. But in fact, you are merely modestly tailoring a preformed report. Now, these preformed reports are useful, and there are situations where this is exactly what you want. But preformed reports are not enough, and certainly not enough to boil the ocean. They cannot satisfy the infinite questions you must support. Okay, but I have to take baby steps before I think about this bigger problem. This is a common line I hear. But wherever you are in your business intelligence reporting journey, you must understand the end game. To architect your early stage solutions, to maximize efficiency and value, As Wayne Gretzky would say, I skate to where the puck is going to be, not where it has been. With the correct approach and partners, it is possible to benefit from, boil the ocean, infinite capability. Even as you broadly roll out early-stage BI solutions for the majority of your customers. So how can I give you achievable infinite analytic power? To achieve infinite analytic power, you need software incorporating simple, reusable analytic patterns, used in infinite combinations. So the patterns are simple, they are few in number, but they can be used in infinite combinations. This allows you to use all your data from all your systems to work together to answer questions. Accessible to and usable by a large number of content experts with modest training. Now, why do you want to make data easily accessible to a large number of content experts? More minds, more thoughts, more questions, more creativity. Low barrier to information creation creates more information. Low barrier to data review creates an army of people to quality check your data all the time, at no cost to you. Now, you are familiar with the power of simplifying patterns. You just don't realize it yet. Consider for the moment the number of ideas or questions that exist on our planet. They're infinite. Consider the number of vocabulary words that can capture these ideas or questions. Well, for the average college graduate, it's about 75,000 words that capture the infinite. Consider the number of phonemes, these are the number of sounds your mouth makes, in order to capture the vocabulary words that capture the ideas or questions. There are 46 of them. So 46 phonemes capture 75,000 words that capture the infinite questions. And then, how many letters, which are 26, that capture the 46 phonemes, that capture the 75,000 words, that capture infinity. So with the right pattern, you can capture the infinite. Once these patterns are established in software, you can empower your users to answer their own questions. When their approach is valuable, you can clone their solution in a productional environment, for dashboards, for fixed reports. When they build a valuable cohort definition for operational use, you can disseminate their cohort for your institution's use. As core targets of your institution's Slicer and Dicer's business intelligence technology, thereby creating a mutually reinforcing, information creating ecosystem. Let's remember that big healthcare data is useful when you can transform data into temporally enriched information. That information answers an actionable question. You act upon the answer. Results of that action are detectable. You have a methodology to evaluate the results. The implications of that evaluation drive your next action. And you now have a cycle of a learning system. And that's what all this is about. Data to information to action to correction to new action. So let's consider for a moment what is the temporally enriched cohort pattern. For those who are interested in seeing how we use temporally enriched patterns to answer accountable healthcare questions, you can read my book, Riddles in Accountable Healthcare. It's available on Amazon in paperback and available as Kindle as well. If you buy the paperback, you get the Kindle version for nothing. Information must be patient-focused and temporally enriched to be patient value-centric. Just to say that again, information must be patient-focused and temporally enriched to be patient value-centric. Let's consider how information is stored, usually, in healthcare systems, and how it really needs to be in order to be patient value-centric. So consider for a moment how the financial systems look in admission. They ask how many admissions existed in 2011. But the patient value-centric question asks how many unique individuals were admitted. It makes a big difference whether 100 people were admitted once, treated, cured, and sent home, or one person comes in 100 times. From a financial point of view, it makes no difference at all, but from a quality point of view, and certainly from the patient's point of view, this is profoundly different questions. A patient volume-centric question would ask how many visits were there for hypertension? How many slots were filled in the hypertension clinic? But the patient value-centric question asks how long does it take us to control hypertension? Do we bring the hypertension under control? Is a patient now normotensive? And will they be able to get into old age without a stroke? A patient volume-centric question is how much do we spend on drug X? While a patient value-centric question asks how rapidly do patients improve on drug X? This is a profoundly different question. The question that's most important to the patient-centered medical home, accountable care, and frankly to the patient themselves. Patient-centric temporally enriched cohorts. This is a key concept. So when you think of a cohort, you think of the unique individuals, the medical record numbers of the individuals, but the temporally enriched cohort has associated with each individual patient record number an index date time. And the index date time is a date from which elapsed time will be calculated and observations will be made from this point forward in time, from this time before. That's what a temporally enriched cohort looks like. Let's see if we can understand this concept a little better. Let's say we have 10 patients who come into the clinic and declare themselves to be diabetics. And here they are as green circles, declaring themselves diabetic some point between 1/1/2010 to 1/1/2011. Physicians in the clinic actually follow them and notice that they eventually come under control. Let's say their hemoglobin A1Cs come under control. And now we want to evaluate how well these patients have done, how well the doctors have performed in treating these patients. Well, what you can do is you can use a standard HEDIS measure. And what a HEDIS measure does is it takes a look calendarically, cross-sectionally in the year 2010. It says how many diabetics do you have and how many diabetics got to the good outcome. It says that 4 out of 10 got to good outcomes, and that's your success rate, 40%. But is this a fair way to look at these patients? Is this a fair way to evaluate a doctor? Let's take a look at patient number 9. Patient number 9 was brought under control very quickly. Unfortunately, the success was recorded in 2011. So the cross-sectional look in 2010 doesn't recognize this patient's success. In fact, it recognizes the doctor as a failure, the patient as a failure. And consider what this is doing. This patient is a failure only because he came in at the end of the year. When doctors begin to realize they're going to be penalized for this, they're not going to draw blood tests at the end of the year. Moreover, they're not going to accept a patient at the end of the year because it's only going to look bad on their report card. So you've created a metric that's counterproductive. What you really have to realize is that each patient lives in his own time zero. It is the elapsed time, not the calendar time, that's important. Each person should have his own index date time from which all analysis is calculated. So what our system does, what our looking glass system does, is it takes all these patients and zeroes them to their own zero time. And it changes the question from being who got better in the year 2010 to who achieved the outcome within 1 year of follow-up. When you use this slightly modified question, this is a fair question. Everyone had at least a year for follow-up time. And now you find that 5 out of 10 instead of 4 out of 10 were under good control. And patient number 9, who previously was unfairly tarred as an unsuccessful patient, is probably recognized as a successful patient. This is the power of the time-enriched cohort. And Looking Glass Clinical Analytics does this automatically. The same power that powers this QI analysis can power research and evaluation. To make these notions real, I will give you a 15-minute taste of a tool that executes on a repeatable pattern concept. Looking Glass Clinical Analytics Demo. Let's demonstrate the use of Clinical Looking Glass. First put in your username, and then put in your password. Let's go to Event Canvas and actually build a cohort. On the left-hand screen, you can see the management pane. Let's build a cohort. We're going to title it Diabetes. And below we have the editor. Let's first define the event that defines the patient as a diabetic. Now we could choose many things. Let's take a look at what are the different event types that we could choose from. Let's see what we could choose. We could choose an inpatient admission with a diagnosis of diabetes. We could choose a lab test, and that could be a hemoglobin A1C or a very high glucose. We could look at medications ordered in the hospital, like glucophage or insulin, and define a diabetic based on that. We could look at a problem list, physician actually declaring the patient as a diabetic. We're going to use lab test. Now we're going to add a condition, and that condition is going to be lab test type. And now you're going to see all the different lab tests that are available to us. We're going to choose hemoglobin A1C. So the patient must have a hemoglobin A1C, and further, we're going to require a condition that the actual value for the hemoglobin A1C is greater than or equal to 9.5. I think everyone would agree that a patient with a hemoglobin A1C greater than 9.5 is clearly a diabetic. And so we've created that element for the criteria. Now let's give a durational definition. This is a time definition. This is when we're going to be looking for this patient. Let's look for this patient from June of 02 to June of 03. And it's simple enough. Checkbox means it's including that date. 6102 to 6103. So now we have the time interval. And let's add another criterion, which is demographic definition. And I'm going to look for people ages 21 to 65, but let's take a look for a moment and see what conditions I could have actually used for demographics. I could have done it on age, on city, on ethnicity or gender, primary language, race, socioeconomic status, the presence or availability of a social security number. Let's just use age. And we're going to use age between 21 to 65. So we now have the three components. The event is the hemoglobin A1C greater than 9.5. We have time, June of 02 to June of 03, and age, 21 to 65 years old. And we're actually going to build this cohort. Note, the cohort is defined by the earliest, index event line, the earliest laboratory test in this range for an individual between June of 02 to June of 03, age 21 to 65. You will see we have a total number of 3,130 people. Let's add another condition. I want to see how many of these people are actually seen in follow-up with a repeat hemoglobin A1C between 180 days to 365 days. So we have to define the event, and this event is a repeat hemoglobin A1C. And here too it's a lab test, and we add a condition, and that condition is lab test type equals to a hemoglobin A1C. Repeat hemoglobin A1C 180 to 365 days after the diabetes event. And now we're going to build this. As you recall, originally we had 3,330 odd people. Now we have 1,891 people. That is, we have lost 40% of the patients in follow-up. This is the power of Looking Glass's temporal capacities, in that it takes the original cohort and it follows them across time and then says how many of them actually were seen again between day 180 to day 365. Let's review the patterns you have seen. Build a cohort. On the fly, identify patients who have experienced defined events. Those events are temporally related. Use a temporal operator such as within. Look for a follow-up event or a follow-up lab test, like a repeat hemoglobin A1C, that occurred within 180 to 365 days after the index of 8 time. A repeat hemoglobin A1C with a specific value within a certain time period. Look for a follow-up hospitalization event that occurred within 0 to 365 days after. An infinite combination of your infinite events and attributes. A good place to read this is in Riddles in Accountable Healthcare, Chapter 8, Am I My Brother's Keeper? The Longitudinal Healthcare Paradigm, available in Amazon as paperback or Kindle. We'll now show you another demonstration of the repeatable analytic pattern. Now that we've learned how to build cohorts, let's use those cohorts that we've built in Study Designer to look at actual outcome analyses. Let's look at a study that I've already built that looks at diabetics who were young, between the ages of 21 to 65, some who were brought under good control and some who were under bad control. That is, in the days 180 to 365 days after their identification as diabetics, they ultimately were brought under good control, less than 7, or bad control, greater than or equal to 9. Let's take a look at how we actually define criteria in Study Designer. Notice that the main tab showed us the groups. The method section now shows us this metaphor of a raceway. You have a start flag, you have a raceway, and you have an end flag. Everyone starts at their own time 0, that is, when they were brought under good or bad control. You follow them down the racetrack for 365 days until they get to an outcome, which is admission. The racetrack metaphor is very easy because you can go forward in time, but similarly you can go backwards in time with your start flag to the end flag. We're going to go forward in time and look to see how many of those patients who were brought under good control and how many of those patients in bad control ultimately resulted in a hospital admission. Let's look at the results. You can see you have your good control people had 178 males. Your bad control people had 406 males. The age breakdown is in percentiles. So the 50th percentile of the good control was 52. The 90th percentile was 62. That means 10% were older than age 62. And 90% were younger than age 62. Now let's look at our outcomes. Let's maximize the screen. Here you have a nice graphic. On the x-axis are the number of days that have gone by since the start time for each individual member of the cohort. On the y-axis is the cumulative percent of that cohort that has been admitted to the hospital by that day. So let's take a look at the orange group. On day 100, 10% of that orange group had been admitted to the hospital at least once. And by day 365, 20% had been admitted at least once. And what you can clearly see is that the orange group and the black group diverge. The orange group come into the hospital faster than the black group, and it's highly statistically significant, 0.01. As you might expect, it is the bad control group, that is the orange group, that is coming into the hospital faster than the good control group. Below we have a table that summarizes the breakpoints at each of the different days. But at 365 days, you can see that 21% of the bad control people were admitted to the hospital, whereas only 15.3% of the good control were admitted to the hospital at least once. This looks at time to first admission. Let's look at all admissions, or all events. The good control people had 131 admissions. Whether they were first, second, or third, there were 131 of them. They had a total of 151,121 days at risk. These are the days that they were followed in the year post their original control of glucose, and during which time they could have been admitted to a hospital. The bad control people had 464 admissions, for a total of 391,717 days of follow-up. If you take the numerator number of hospitalizations divided by the denominator of person days at risk, you get an incident density of the good control people and the bad control people. If you take the incident density of the bad control people for hospitalizations and divide it by the incident density of good control, you get a relative risk of 1.366. You're 1.3 times more likely to be admitted to the hospital if you were in bad control than good control. And Looking Glass also gives you the confidence interval below of 1.1 to 1.4. Now suppose you actually wanted to see the patient list. You click this button and you have a breakdown of the patients and some of the variables. What you'll notice immediately is that this is a de-identified sample. We do not have any names or any medical record numbers. Everything, in fact, you've seen so far has been in what's called the restricted mode, so that you can protect patient privacy. But let's say you actually wanted to follow up these patients. You actually wanted to do something with them. You could click this button which says Show Identifier, and you're immediately challenged by the HIPAA validation. You can tell the HIPAA validation request that it's a QA project if you've registered it. If it's an Institutional Review Board approved research project, you put in the number. If it's a patient work list, you're in a clinic and you're trying to find all the people, for example, who need pap smears, you write that down here. And what the system now will record is the date, the time, the person who looked at the clinical data, the very question they asked, and the contemporaneous justification. This is fully auditable and can be used to make sure that patient privacy is maintained throughout. In this case, we will not look at identifiers because we really don't need them. Now, everything you've seen so far has been in the de-identified mode. Suppose you wanted to give a summary of this work that you've done to a colleague or to the IRB in anticipation of a study, but you don't want to share any patient identifiers. That's very easy. You clicked on the PDF button that I just showed you, and a PDF document is generated, fully documenting all the details of what you've already seen. As you may recall, you had your demographics, your target events, your all events. You have your definitions of your groups, and you have your methodology. And now you can share this with a colleague without worrying about violating HIPAA or violating patient privacy. In addition, once you've completed your study, you can share it with colleagues, and someone else can begin from where you left off. Let's review the patterns you have seen. You learned how to build a study using the racetrack metaphor: the start flag, the follow-up time to the end flag, and the outcome. Included in the study is infinite variability of the cohort you can choose, the outcome you can choose, and the elapsed time. and in fact whether the elapsed time is forward or backwards. What are our events? Let's just remind ourselves of that. A laboratory test is an event. A hospital admission is an event. An emergency room visit is an event. A medication prescription is an event. A systolic blood pressure is an event. Pain score is an event. Cardiac echo study is an event. These are things that happen to patients, and you can define a patient by the things that happen to them. And revenue, of course, for our financial colleagues is an important event as well. Events with attributes should be routinely enrolled in Looking Glass as new systems are activated in your institution. This simplifies cohort building criteria and list report creation. Let's talk about what are the attributes of the events. I've talked to you about what the events are. What are the attributes? So for example, a laboratory test event has an attribute that is type. What type of laboratory test is it? Is it a hematocrit, a white cell count, a serum sodium? What is its numeric value? Is it 140? Is it 3.5? What is its categoric value? Some laboratory tests come back as positive, negative, and determinant. And is there a text associated with this test that we can potentially search for the word that we're looking for? What are the attributes of an inpatient admission event? Well, there are a good number of them, actually. There's an ICD-9 or ICD-10 diagnosis, which has a numeric value, which has a human recognizable English equivalent, which can be present or absent on admissions. These are attributes of the attribute. A primary or secondary diagnosis. You can have an admitting physician attached to the hospitalization. That is an attribute of the hospitalization. You can have a DRG, a diagnostic-related group, attached to the hospitalization. You should have a length of stay notion attached to the hospitalization. Disposition at discharge, such as discharged alive or expired, and a referral source. Do they come from a nursing home? You relate each event to each other event by the pattern of advanced time operators. You've already seen the within operator. So within a window of elapsed time, anchored by the patient index date time. Right? So you found whether there was a repeat hemoglobin A1C within 180 to 365 days of the original one. We also have an advanced operator when in that actually causes certain events to occur during a durational event. I want the echocardiogram during a hospitalization. I want the first creatinine during the hospitalization. I want the last creatinine during the hospitalization so I can see whether there's been a change in the creatinine. I want a diagnosis during a prescription duration. And of course, your routine time notions such as when in calendaric, an event occurs during a time period, very classically, between January 1st, 2014 and January 1st, 2015, find this event. Now, there are a few other patterns that exist in Looking Glass Clinical Analytics, and we don't have a lot of time to go into it, although if you go to my YouTube playlist, you'll actually see further discussions of these. There's a study list method. It permits you to associate any event with any cohort to view that event's attribute. So let's say you have a group of patients who are hospitalized with congestive heart failure. That event is a hospitalization. You want to find the cardiac echo that occurred before the hospitalization, and you want to know what the echo ejection fraction was. You might want to find all the revenue 6 months after the patient joined our clinic. We also have a study time and range method. This allows you to summarize continuous values across time, bucketing the amount of time in each range of values. So how much time was the patient's sugar in good control? How much time was the patient's blood pressure in good control? How much time were we spending too much money on an expensive drug because we had already gotten his blood counts in the right range and we didn't have to use more of that expensive drug? So you'd be able to reduce the drug dose and therefore the cost of that drug. Now, how does the cohort model play nicely with business consumers who don't want to build cohorts but want to use its power? Well, if you think about it, you have the feeder systems, you have the enterprise data warehouse or data mart. It doesn't have to be a complete warehouse yet. And from that data warehouse, Looking Glass Clinical Analytics sits on top of it and can generate objects that can feed performance dashboards, registries, predictive solutions, report cards. So the same technology that feeds you in this advanced way or presents in an advanced way your ability to make sense of your observations also allows you to create objects that can feed these much more common tools that people often like to see. So let's consider for a moment what a financial calculator would look like for population health control. So let's give an example. Let's identify patient costs for patients who were diagnosed with cancer in the hospital for the first time in 2014. These are patients who show up in the cancer registry, and their date of cancer registry activation is during the hospital stay itself. Identify all those patients and follow them for 6 months, accumulating all their costs. Feed the cohort to your display technology, Excel or a dashboard. We're going to do it to Excel just to give you a flavor of how easy it is to do. So here's a financial calculator. We've moved the data table that we've created as a result of creating this object in Looking Glass into Excel. And we've just summed all the revenue for all the cancer patients and provided for you what the category was. This is acute lymphocytic leukemia. Here are the cancer patients. And here is the 6-month expenditure. You can see it ranges wildly from $84,000 to $642,000. Tremendous variability. And once you have it in your spreadsheet or your dashboard, you can use all the tools you normally associate with that. This is all the revenue. You can click on this. It opens up, as you know, in a spreadsheet, different options. You choose home health care and you hit OK, and now you see the amount of money spent on home health care for those different patients. You want to look at a different element, such as technical hospital. You hit that, and you have that information. If you want to do professional ER, you've got that information as well. And you can see how you could quickly get a sense of pharmacy and all the other elements of cost that belong to these patients by using the cohort method that collects all that information across time. The pattern is reusable, it's simple, and once you build it in place, you're able to do remarkable things with it and feed such simple technologies as Excel or dashboards so that your other users who don't want to be involved in building the cohorts can actually benefit right away. What would the dashboards look like? Well, just again to remind you, you have all the source information. Goes into your data warehouse or data mart. It doesn't have to be a fully developed data mart. It doesn't have to be a fully developed data warehouse. You put Looking Glass Clinical Analytics on top of it, and then you get your dashboard with all the usual nice pictures. Here's an example of what an accountable care dashboard might look like. You enrolled cohort A, you have a start date, you have an end date, you have the age range. All these things are movable and controllable for you quickly. Facility, gender, the race, language, ethnicity. And your dashboard itself is already prearranged to give you the sort of information you want, whether it be the breakdown of weight in terms of grossly overweight or just overweight, whether you have the blood pressure overall under control, or those with diabetes with good blood pressure control, or those with renal failure and good blood pressure control. And as you change the controls on the side, changing race, for example, these change as well. Change ethnicity, these change as well. So you can create a scenario where you create your cohorts, you feed them into your dashboard, and now your dashboard is going to be very plastic. And it can have all sorts of usual dashboardy things that you want to look at. Even geographic, where you have a zip code and the concentration of patients. So let's review. The solution for near infinite demand against finite resource requires that you bring your resource to where the question is. You don't have to turn out millions of reports. You just need discipline. Enroll your U events into a software solution, to register events and attributes, to provide reusable analytic patterns. An information creation model must have an information architecture stack that is affordable, sustainable, eliminating the report requirement creation and the infinite back and forth with a customer for multiple versions of the dataset. You're doing this right now in your IT shops. Somebody gives you a request, you give them the information, they ask you for more data, it goes back and forth. It's an infinite loop that never gets finished. It gets report writing out of IT, out of information technology, and into the hands of those who are directly responsible for analysis and outcome. And this is the important point. It encourages the institution to hire and promote efficient consumers and creators of information from your empowering information stack. If you build a tool like this, there is every incentive for your institution to seek out people who will use the tool. And once they use the tool, they will do good things with it for the institution, they will identify their own value to the institution, and they will reduce the amount of work that you have. Because with each new hire, your work in reporting is reduced, since their need is automatically met by their own efforts. So to give you a flavor of this, Montefiore Medical Center in the Bronx, this is our Looking Glass experience. Between January 1st, 14 to October 22nd, 15, we had 843 unique users log in. They logged in a total of 34,055 times. This doesn't even include all the studies they ran during the login, but this is the number of logins they had. I'd like to make some acknowledgments here. Obviously, my book, Riddles in Accountable Healthcare. If you want to see more of how you actually use this and how you actually think about repurposing data that exists all around the place into something meaningful for delivery of healthcare, it's actually quite an interesting book. Only 3 to 5 pages a chapter and about 28 chapters. Looking Glass Clinical Analytics, Streamline Health. This is a company that is commercializing Looking Glass. We built Looking Glass in Montefiore Medical Center over 15 years with about $40 million of investment. Streamline Health is now marketing it under the banner of Looking Glass Clinical Analytics and can make it available to you in a very short period of time. Cassiopeia Tech, this is a group of people who helps me with dashboards. And of course, you can go to our website, exploreclg.montefiore.org, and here as well. You can also go to my YouTube website, my YouTube playlist, Eran Bellin cohort playlist, YouTube, and you'll find me there with the lectures I give my medical students.